So this was when AAIC was there in 2022, and I remember I was actually when I took this picture, and I was walking back to my hotel with my wife, and I remember looking out on that canal, and I saw the sun was still kind of up, and I looked at my phone, and it was 11:22 at night. And so it totally was threw me off. I was like, oh my gosh, I have to have a picture of this. I'm gonna remember this is 11:22 p.m. and the sun was still barely up. So
Yeah, it's pretty far up north.
yeah.
Yeah.
All right, Mark, I'll go ahead and get started and then introduce you. So welcome all to this webinar today. My name is Mike Malakamati. I'm a statistician at the Banner Alzheimer's Institute in Phoenix, Arizona. I'm also a part of the Arizona Alzheimer's Disease Research Center Data Management and Statistics Core. We are the ones who host this webinar series. And we're very glad to have today's speaker, Mark Doubleman, with us today. Just a few things to note before we get started. This webinar is being recorded, and after the completion of the webinar, I will be posting it to a YouTube page where it will be accessible after that, and I will email the link out to everybody once it is available. Any questions that you might have, I will moderate through the chat function, so you can submit your questions you might have through the chat, and at the end of the presentation, I will moderate those questions. And also anybody who it might be interested in actually giving a talk for this webinar series, very happy to entertain any proposals for that. So you can email me with anything you might be interested in presenting. I'll put my email in the chat to be contacted with. In addition to that, Mark is also going to be doing another webinar next month, sponsored by iStart. And I highly encourage all of you to register for that and attend that as well. I'll be putting the link to register for that webinar into the chat as well, so you can see that in a little bit. But without further ado, I will go ahead and introduce our speaker for today. Mark Doubleman completed his PhD at the Alzheimer's Center of VU University Medical Center in Amsterdam, the Netherlands. His research is focused on measuring changes in everyday functioning in early Alzheimer's disease, including the preclinical stage. His past research projects have ranged from investigating potential cultural biases in the measurement of daily functioning to the relationships between amyloid and tau and functional change. He is currently a postdoctoral fellow at Massachusetts General Hospital and Harvard Medical School in Boston, Massachusetts. All right, with that, Mark, I will pass it over to you to go ahead and get started.
Sounds good. Thanks for that introduction, and thank you everyone for joining. I hope you can see the right screen here. So I will be talking to you today about one of my projects that I did during my PhD in Amsterdam, where we really try to answer the question of what is a meaningful change in everyday functioning in the context of Alzheimer's disease. And I'll just start off with giving you some background on everyday functioning. Everyday functioning or impairment in everyday functioning is considered the start of the dementia stage. So it's kind of part of the definition of dementia as being dependent on others for daily activities. But as we all know, cognition changes gradually over the years preceding dementia. And so even in earlier disease stages, we can detect changes in everyday functioning, specifically in more cognitively complex activities. We call those instrumental activities of daily living, or IADL. An IADL measurement is traditionally, it relies on study partner reported questionnaires. So those are questionnaires completed by a spouse, a child, another family member of the patient. Um, and that's because in the dementia stage, people may not be aware of the problems that they have. So they might report that nothing is going on, but then when you ask the spouse or somebody who is close to them, they might say, well, actually, they do have some issues. So that is kind of traditionally what we've relied on as we're moving into earlier disease stages. I think we're also looking more at self-reported questionnaires as well as performance-based measures, which try to kind of get at IDL functioning in a different way. Um, but the research that I'm presenting today is going to be based on on a study partner reported questionnaire. And a lot of my work is focused on IADL, so I'm passionate about it, and I think it's very important. But I would say, and from a clinical perspective, IADLs are important because they relate to somebody's independence, and really IADL problems are the first things that people are going to report. And so I think it's an important outcome measure, even in preclinical stages or prodromal stages of Alzheimer's disease and related disorders. Um, and the question is, though, how can we know when a change in IDL is noticeable and meaningful to the patient and to their family and to the clinician? And that's a difficult question to answer, but it's also an important one. Specifically, also in the context of drug trials, there's a guidance document by the FDA that emphasizes that a clinical efficacy of new drugs should be judged by the ability of that drug to have a meaningful effect on relevant outcome measures. And I would say IDL is a relevant outcome measure. And there are various ways to measure or define clinically meaningful changes. The most common ones are the data-driven, anchor-based, and qualitative methods. And I personally don't think that data-driven methods are really about clinically meaningful change because in those methods, people will maybe look at if a change is statistically significant or um, something like that, or which is not informed by the stakeholders. It's not asking the patient or their family what they think is important. It's just looking at the distribution and the statistics, which is important for other things, but not maybe for trying to define what's clinically meaningful. But the other two methods are better at that. So in anchor-based research, what people will do is they'll look at their outcome that they're interested in and then have an external question or a survey or some other measure that they can use to kind of judge whether the change in the outcome is meaningful. So, for example, you might administer your measure of your outcome measure of interest at baseline and a year later, and then also at that year at that 1 year follow-up point, you could ask, did you notice a change? Yes or no? And then you can look at people who said yes, do they change more on your outcome or something like that. So that's a good way to do it. It's pretty easy to implement. The kind of downside of anchor-based methods is that they're reliant on the anchor. So if your anchor isn't that good, then you're not going to be able to do much with your data. And another thing is that people are kind of um, not so good at reflecting on change, so they'll most likely report on the current state. So if somebody already has a lot of problems in daily functioning at baseline, but also at a year, they might say there was a meaningful, significant change, even if objectively they didn't change that much on the measure that you have, just because a lot of problems are present at both time points. So the kind of other answer is to use a qualitative method where you really ask people to judge your outcome measure and see what they think is clinically meaningful. And that's what we've done. So I'll be talking about that a lot more. Um, and really the goal of this study was to determine the minimal important change or MIC. And there's different terms for it, but I'll call it MIC. um, which has been defined as the smallest within-person change that is important to the patient. Um, And for this research, we used the Amsterdam IDL questionnaire, which is a study partner-based questionnaire, although a self-report is now also available. Originally, it included 70 activities, but it's been shortened to a 30-item version. And that was done in part to reduce administration time and burden on the person completing it, because answering 70 questions is kind of a lot. Um, and also another objective of that was to make it a little bit more culturally relevant. So in that process, they involved researchers from different countries just to identify the items that they thought were most relevant. Um, because as you can imagine, what daily life looks like differs a lot between cultures and countries, and what's common here might not be common in other places, or for people with a different cultural background. So we want to make it as universal as we can. Um, Although that is of course hard, but with the 30 item version, we kind of are able to um, apply the questionnaire in different countries and have a measurement of IDL that's kind of universal. And I think one kind of benefit of the Amsterdam IADL questionnaire that it has over a lot of other IADL questionnaires is that it uses this adaptive design where for each activity, the initial question is, did the person even do the activity? So, for example, did they cook? If yes, if they did, then we ask how much difficulty or how much more difficulty did the person have performing that activity? So how much more difficult was it to cook compared to earlier? But if they didn't do the activity, if they didn't cook, then the question is why not? Because we're trying to get at a measure of IDL functioning in kind of because of cognitive functioning. So we're interested in issues or problems with daily life due to cognitive changes. So if it just is not an activity that somebody does, if it's not their role in the household to cook, then that doesn't really contribute to what we're trying to measure. So we regard that as not relevant and don't include that in the scoring of the item. Um, and each item is then kind of rated on a 5-point Likert scale that ranges from no difficulty performing the activity to being unable to do the activity due to cognitive problems. Um, and we compute the total scores for the Amsterdam IDL questionnaire using item response theory, the graded response model. For those of you that aren't familiar with IRT, IRT assumes that there is a single latent trait that we want to measure with this questionnaire. We can't directly observe it, but we use the questions to kind of get at that trait that we're trying to measure. And the trait is represented by theta, and theta is centered around a mean of 0 with a standard deviation of 1, and it's normally distributed. So this is what a theta distribution might look like. Um, and each question, or rather each um, response category to each question loads on the latent trait and can be placed on that scale at some point. So for example, you could say that response option 3 to item 4 falls on this particular part of the scale. And we can do the same with individuals' total scores. So we can say somebody who scored negative zero point 0.8 will fall on this point of the scale. So that's kind of an advantage of IRT over using a sum score, where we can go from one item score to the total score and the other way around. Um, the the total score for the Amsterdam IEL is converted from theta to a t-score with a mean of 50 and a standard deviation of 10. And higher t-scores indicate higher levels of the trait of IADL functioning. So higher scores are better. And that t-score was calibrated in a memory clinic setting, which is a little different from how IRT models are often calibrated. It's usually in a healthy population, but in this case, we used a memory clinic setting just because that's the relevant population for the questionnaire. So a T-score of 50 represents an average person reporting to a memory clinic. So now we have the total score, but the question remains like, what does that score mean? A T-score or any score in and of itself doesn't really have an intuitive meaning, because if I was a clinician and I told you you have a T-score of 40, then that doesn't really mean anything to you. And let alone comparing it to another score, like how does a score of 40 compare to a score of 45? So before we can even start to look at changes in IDL, we wanted to look at what does just a given score mean. And to do this, we organized focus groups with caregivers of dementia patients, and we sent out a survey to clinicians to get input from them on what they think a certain score means. And we used a method called bookmarking to do this. Um, and in bookmarking, we present fictitious patients with various levels of the traits, so various T-scores in a random order, and then ask the panelists to sort them from least to most problems. And then when they have them sorted, we ask them to identify cut points to distinguish different categories in the trait level. And they kind of do that by placing a bookmark, so that's why it's called bookmarking, between two cases where they think um, it goes from no to mild problems, and from mild to moderate, and from moderate to severe. And those four categories, we predetermined that we wanted to use those for um, in our outcomes. So that's kind of the way that it was set up. Um, so how do you turn a score into a patient? Well, with IRT, the nice thing is that you have item information curves, which can tell you a little bit about what the item or how well the item measures, how much information it can give about the latent trait, and also where on the scale it falls. Because you can imagine that some items are better at measuring low levels of the trait and others are better at measuring high levels of the trait. Um, for example, managing finances or being on top of your bills is a more complicated activity compared to preparing a sandwich, which is also an IADL, but it's um, a little bit it's not as big maybe. So when you use two items, one will be on one end of the scale and the other might be on the other end of the scale, and that we can see that in the item information curves. And we use those curves to select a top 15 out of 30 items to create a pool from which to make these fictitious patients. And that was just to make it a little bit easier for ourselves because it was a pretty big puzzle to create these summaries. And we wanted to represent in the summaries, we wanted to represent the full range of the traits, so from very impaired to very minor problems. And so we used the items to create short clinical summaries using the most likely item responses for given T-scores. So I have here a table with just a few example items from the questionnaire, and you can see for various T-scores what the most likely item responses that somebody will give with that certain T-score. So, and you can also see in this table kind of how, for example, the item working is harder than the item preparing sandwiches because somebody with a T-score of 45, which is pretty close to the mean, still is unable to work, whereas somebody with a T-score of 30, which is two standard deviations below the mean, is able to prepare sandwiches, although with more difficulty than before. So um, with this overview, we created the summaries. For each summary, we selected 5 items out of the 15 to include them into this kind of brief overview. And we also gave them a random sex. We gave them a surname and added a stock photo to make them feel like they were real people. So in that way, we can go from this kind of T equals 45, and that means cooking is 2 and preparing sandwiches is 1, that kind of not um, suitable summary for lay people to this. So this is what the summaries look like. They have a name and then a short description of the problems that the person had in the past 4 weeks. And then also in bullet points, just kind of an overview, which should make it a little bit easier to compare different summaries. And it is important to note that the panelists were blinded to the T-scores. So they didn't know that Mr. Williams had a T-score of 45. We created 9 summaries in total, and they were each 5 points apart, and they covered the entire range of the scale. So people got kind of 9 pieces of paper with those summaries that I just showed you, and were then asked first individually to sort them from least to most problems. Then and this was in the focus groups that we organized. Then in the group, we discussed what does it mean for you to have mild problems or moderate problems or severe problems in IADL to kind of get an idea of what people even consider mild or moderate. And then we had them place the summaries into those 4 categories individually first. And then again, we went back to the kind of group setting where people, one after the other, presented their categorizations. And then we had a consensus discussion where we tried to end up with one categorization for the whole focus group. And we did this twice. The focus group was pretty small. I think there were about 5 people in each group, so a total of 10. And we also sent out a survey to clinicians separately, where obviously there was no group discussion part of it, but the rest of it was the same. And we averaged kind of first within the clinicians and then from the 2 focus groups and the clinicians into the final kind of categorization of understanding the scores. And that looked a little bit like this. So here's the total T scale that ranges from approximately 20 to 80. Mr. Williams, the summary that I showed you is 45. And then the focus groups kind of came up with this categorization where severe problems or scores lower than 40 represent severe problems. Scores between 40 and 50 represent moderate problems, between 50 and 60 mild problems, and higher than 60 no problems. And that was kind of our first step. And this exercise also kind of was a confirmation for us that the T scale is accurately represented by the summaries that we made, because people were generally able to sort them in the correct order. I think there was only one participant or one panelist who kind of had a couple switched up, but most of them placed them in the order that they fell on the scale, which is a good thing. And there was pretty good consensus also between the individual panelists, but also between the separate focus groups and the clinicians on the categorizations. I think the only thing was that the clinicians placed the threshold for severe problems a little bit higher than the caregivers did. So that's also something interesting to know. But this is what we ended up with. And that kind of allowed us to move on to the second part, which was really asking what does a change mean and how do we establish thresholds for minimally important change? And for this, we ended up with a much larger sample of caregivers. We recruited them through the Dutch Brain Registry, which is just kind of a registry of people who are interested in brain-related research. We approached them. I think this was like pretty shortly after the pandemic hit and the first lockdowns were in place. So I think people were kind of looking for something to do. So we had a really good response rate there because it was an online questionnaire. People could just do it from home. Um, we looked for people who were the caregivers of people living with dementia, and we showed them 7 different situations where the functioning of a fictional patient changed over 1 year. And that might sound very abstract. It kind of looked a little bit like this. So this is just a condensed version of what it looked like. We would show side by side 2 summaries like the one that I showed you, and I've just condensed it here a little bit to make it fit on a slide. So each respondent would see one patient, and then we would show them 7 different cases where their scores changed. So in this case, Mr. Williams last year had a score of 46 and now has a score of 42. Again, the respondents didn't know that, but we asked them to compare um, last year and now and indicate if they thought that Mr. Williams now has worse or that his problems are worse or better or the same. And if the respondent said, "Oh, I think it's worse or better," if there is a change, then we asked them, do you think that that would be a meaningful change? So would you notice that if this was um, your loved one living with dementia, yes or no? And we've repeated that process 7 times. So we showed them kind of different now situations. Each time they had to kind of think again about, is there a change, yes or no? And if there is a change, is it meaningful? Um, and so the amount of change changed, differed from an 8 point decrease to a 6 point increase from the situation last year. So we wanted to look at both meaningful decline, but which is kind of what we would expect, but we also wanted to know about meaningful improvement for, therapy or treatment if we're going to get to that point where we can actually improve function, then we want to see, is it meaningful, the improvement? And so we kind of separated those two. We looked at decline and improvement separately. And we placed thresholds for each individual respondent at the smallest difference that they would judge as an important difference. So it could range from 2 to 8 points for decline, or from 2 to 6 points for increase, because the summaries here were not 5 but 2 points apart, so they were a little bit closer than before. And then we averaged the individual thresholds to represent them, make the minimal important change. Um, and then another thing to make it a little bit more complicated was that we assigned our respondents into one of 6 groups, and each group had a unique fictional patient. And that fictional patient had a different starting point each for each group, so that we could cover the entire range of functioning. Because we thought about this kind of a lot, like how many situations do we want to show? Because it is kind of a difficult exercise. So we didn't want to show people 20 different situations to judge. So we limited it to um, just the 7, and then kind of to overcome the fact that with 7 cases we cannot cover the entire range, we kind of divided the group into these 6 smaller groups. And another benefit of that is that we were able to see if somebody who already has a lot of problems to begin with, um, for that person, maybe the amount of change required to be a meaningful change might be different from somebody who doesn't have problems yet. So that way we could also investigate that. Um, Now, like I mentioned, it was a pretty difficult exercise, and got that back from a few respondents as well, who were like, this was really hard. And so there are a couple of misjudgments that we found in this exercise, and there were two main types. So the first one is an out of range judgment, which is where a situation that is really showing a decline is judged as an improvement or the other way around. And the other type is a paradoxical judgment, which is when a larger change is judged as non-important while a smaller change is judged as important. So if somebody said a 2-point decline is important, but a 4-point decline is not important, then that would be paradoxical, because you would expect that there's the smallest change that's important, and then any change that's larger than that should be important as well. And about a quarter of the participants made paradoxical judgments for decline, and a little bit more made paradoxical judgments for improvement. And especially in the situations that oh, I think I made a mistake here on the slide. It should be especially in situations representing improvement, respondents made out of range judgment. So a lot of respondents actually, um, for the 2-point increase, I believe it was about 90% of the respondents judged with that improvement as being a decline. So yeah, when apparently, and maybe it's the setup of showing those two things side by side, or maybe it's just hard to imagine what an improvement might look like. But yeah, the situations that represented improvement, a lot of people judged them as representing decline. And for the purpose of the analyses, we then considered those judgment as no change, because we couldn't really look at them because they're not in line with the scoring. Um, so this is what we found for the threshold for decline. Out of the 1,600 plus people, almost everybody, except for, I guess, 30 participants, reached the threshold, which means that they judged at least one of the situations that represented a decline as being meaningful. And on average, their threshold was at a decrease of 2.4 points on the scale. So that's about a tenth. No, it's about a fifth of the standard deviation. And I mentioned those 6 groups that we made. So we gave them different names, and they represent different starting points, T-scores. And we imagined initially that if somebody has a better level of functioning at baseline, so Mrs. Smith and Mr. Jones here, they have pretty high functioning. We would expect that a smaller change would be important compared to this Mr. Garcia, which is already at a very low point on the T-scale to begin with. And we didn't really find that. So these differences in numbers, I believe they were not significant. I guess you can see that the Mr. Garcia threshold is a little bit higher. It's almost 3 points versus 2.3 for Mrs. Smith. And there was a little bit of a difference, but not really, which I guess is nice for us, because then we can establish a single threshold for minimal important decline for the entire range of the scale. Um, like I had mentioned, judging improvement was a lot harder, and that kind of also shows in how many people reached the threshold. Um, Only about a fifth of the sample reached the threshold for improvement. So yeah, I guess we can't say for sure if they just didn't consider the situations to be improvement. I guess with the out of range judgments, it would suggest that. But it's also possible that we just needed to go farther up the scale. So our maximum improvement that we investigated was a 6-point increase. It might be that we need an 8 point or a 10 point or a 12 point increase before people see that as important. And you also see that the average threshold is a little bit higher for improvement compared to decline. And there's one group, the Mr. Williams group, where very few people reached the threshold, and we weren't really sure why that was. It just seemed a little bit lower than all of the other groups. I guess, and it's in the middle of the range, so we couldn't really come up with a good reason for it. I guess maybe it's just maybe the fact that this was just a hard exercise for improvement, and I think we might want to do it again with like different summaries or maybe larger differences in on the improvement side, just because it appears to be a little bit harder to find that threshold. But we did kind of average the thresholds of all the respondents, and so it kind of shows that a meaningful decline it happens after about a 2 point decrease on the scale, whereas a meaningful improvement happens only after about a 5 point increase on the scale. So yeah, we definitely reached a meaningful decline pretty fast. It's a pretty small change, 2 points, as you can kind of see on this little graph. And the last kind of step that we took here was to apply the thresholds to real life data. So we took a sample of 230 memory clinic patients who were followed up over 1 year, and they completed the questionnaire. Really, their caregivers completed the questionnaire every 3 months during that year. And then we looked at kind of how many people passed the thresholds of negative 2.4 points or plus 4.7 points, and after how much time do they pass that threshold. And in the group as a whole, we saw that about 45% showed a decline, about 40% showed an improvement, which means that about 15% didn't show a meaningful change over the year. And on average, I guess it didn't really matter if it was improvement or decline. It seemed to occur on average after about 6 or 7 months from baseline, which I thought was pretty fast. But then if we break it down by diagnostic group, we see some differences, and I think some of them are a little bit in line with what we would expect. So people who presented to the um, memory clinic with cognitive complaints, but who didn't have any objective impairments, the SCD group, they were much less likely to show a decline and more likely to show an improvement. Whereas people with dementia, either due to Alzheimer's disease or to a different disease, were more likely to show decline um, after about 6, 7 months. Um, and I wanted to show that in a kind of different way. So here is a figure where the panels group patients kind of comparing their last visit to the baseline. So the left panel is the people who showed a meaningful decline over the year. The middle panel is people who showed no change, and the right panel is people who showed a meaningful improvement. And I colored the lines in the panel by the change from the prior visit. And if you kind of squint at the figure, you can kind of see that in general, people kind of don't change from meaningful improvement to decline or other way around that much. So once you are on kind of a trajectory of decline, you will stay on that, save for a few lines that were a few people that did change a little bit. So I thought it was pretty interesting. And I think those people that do kind of switch around from meaningful decline to improvement and no change, I think that um, those people are really interesting to look at in more detail, maybe, but that's beyond the scope of this work. So I just inundated you with a lot of data. I do have a few discussion points. I think one thing that I think is really important is to realize that we need to understand when changes are meaningful to stakeholders by talking to them, asking them, the patients, their caregivers, clinicians, before we can make claims about meaningful effects. Um, I know that the CDR is often kind of, at least in clinical trials, the CDR is kind of seen as this holy grail where, if there's no change on CDR that's clinically meaningful, but I would want to see a study that kind of really looks at that. And um, I think that, yeah, our study is kind of unique in that sense that we did involve a lot of caregivers um, and ask them what would be meaningful to them. Obviously, we didn't include patients themselves. That would be a very important next step. We didn't do that in this case because it was such a cognitively complex task, and it wouldn't probably be very ethical to ask somebody with MCI or dementia to do that exercise, especially the comparing. Um, Although a way to kind of overcome that would be to ask them to compare fictitious patients to their own level of functioning if they do have insight into it. So there's ways to do it, but it would be something we can do in the future. I also do want to note that what I just showed with the bookmarking and the thresholds is just one example of how you can establish meaningful interpretations of the scores and changes. So it's certainly not the only way. And some of those anchor-based methods are really good and have shown like good results. Um, I do think kind of as more of a something to think about, that these exercises are really made for patient-reported outcome measures, and it's going to be hard if you want to use this kind of an exercise to determine if change on, say, the MMSE or some kind of cognitive test is meaningful to patients. I wouldn't really know how to directly translate that, but that would certainly be interesting to think about. Um, Another question that kind of came up with while we were doing this study was, what effect does the time frame have on the meaningfulness of change? Because you can imagine that if you lose 2 points over a year, that's a much larger change than if you lose them over 5 years or 10 years. So in this case, we really based the thresholds on change over 1 year, but it would be interesting to see if they change if you looked at um, at shorter or longer time frames. And then I guess another kind of more philosophical almost question that came up was if we're running a trial and we find that there is no meaningful decline, is that enough of a beneficial treatment effect? Or do you really need to achieve that meaningful improvement, which at least in our study was really hard to achieve. And I mean, if if we're now able to slow down progression a little bit, then it's going to take a long time before we can add 6, 7 points on a scale with drug treatment. So that's something to kind of think about. And I think I'll stop there, and I'm happy to answer questions that you might have.
Well, excellent, Mark. Thank you very much for all that. We've had no questions come in the chat just yet, so I'll start off with one for myself.
Mhm.
In the beginning, when you really kind of set up the conceptual idea for this minimally important change, did you and your colleagues sort of have a rough estimate a priori of what number was going to you thought might be for your MIC value, or you just went into it, very, agnostically?
We were pretty agnostic about it. Of course, we kind of there's the kind of trade-off between finding the smallest change that's meaningful versus finding a change that's just measurement error. So I think that's kind of how we ended up with choosing for the change steps of 2 points and not steps of 1 point, just because yeah, we thought if somebody changes 1 point over a year on this scale, that is probably just noise that you have. Um, but yeah, the downside of that was that it is possible that the threshold was lower than it was that we found if we had gone smaller. Um, and then I guess yeah, we kind of thought we don't have to go to like 20-point decrease or 30-point decrease, just because that probably is meaningful. So I guess there was a little bit of an assumption in the ballpark area of what it might be.
Oh, excellent. So we do have one question that just came in through the chat from Dr. Kevin Duff. He says, great presentation, Mark. Very interesting results and clearly a lot of work. He asks, how might changes using this method compare to other methods of identifying change? For example, in neuropsychology, we use reliable change indices or standardized regression-based change scores to quantify change. So how might RCIs and SRBs change relate to the ones you found with your method?
Yeah, that's a really interesting, cool question. I think that they're kind of different things, maybe a little bit, because, or as I understand, the reliable change index is kind of more of a statistical change, if I'm like right about that. So uh, I think incorporating what people report is meaningful to them is kind of adding a bit of extra information. Um, and when we're doing just regressions or looking at kind of models of change over time, we're just looking at is there a significant change, but that doesn't really, the significance of a change doesn't directly relate with the meaningfulness of the change. And there's obviously, it's difficult that there's situations where a meaningful change might not be significant or vice versa, I guess. So that makes it a little difficult, but
If I could just interject. So yeah, no, you're exactly right, Mark. The RCIs and SRBs tend to be more of a statistical method of examining change. But I guess I was wondering if you, because what the method you did requires an awful lot of work. And
Mhm.
as you said, it's quite complex. And I'm wondering if you can get the same types of results by using the statistical formula, where it doesn't require all these focus groups. What you do is you measure caregivers, because I still think it's incredibly important to get the perspective of the caregiver and or the patient involved, but measure them at 2 time points and use the statistical formula to see, here's what a reliable or meaningful amount of change is, and does that yield similar results or different results than using focus groups and collecting all these anchors and developing fake patients with real pictures and all that, which again, fascinating to look at. I just wonder if it might yield similar results, but be less work than what you've done, or they may be complementary, that they may provide us different types of information, both very important.
Yeah, I think it would probably be that last thing. So they're probably complementary. Um, I, yeah, it's not probably feasible to do this kind of exercise with any and all outcome measure. But yeah, I think in order to say something about is the change that we detect meaningful, we need at least an anchor, and anchors are a little bit easier, I guess. You can just add a question at the end, to say like, did you notice a change, and use that, and then kind of use that in conjunction with the reliable change or something like that. But and it's actually, yeah, we didn't really look at it. It would probably be really interesting to see because maybe conceptually they're very different, but maybe in the numbers they're kind of similar. So it'd be interesting to do a head-to-head comparison. Um, so yeah, that's interesting. Think about that.
Catherine, you have a question.
Yeah, hi Mark. That was so interesting. I was just curious, I may have missed this in the methods, but were there any kind of free text or other qualitative feedback that you received from participants about maybe other tasks that were missed on the scenarios or the questionnaire that they would find particularly meaningful, just in terms of like, additional qualitative feedback?
Yeah, we did have an open comment box. I think because we tried to set the summaries up in a way that they would represent a global um, level of functioning, we kind of specifically asked them to try to create a mental picture of the patient and not just look at the individual activities that were included. Um, and another way that we did that was in the summaries, we didn't always have the same activities to compare head to head. So they had to really kind of form a general idea, and sometimes it would include one item, and then other times it would include a different one. And some of the feedback that we got was that that was hard, because it's kind of comparing apples and oranges a little bit. Um, but I don't know if the feedback wasn't that we missed anything. I think, yeah, the main kind of feedback that I remember getting was that a lot of people said this was difficult and I'm not sure that I did it right. And so that's certainly something to be mindful of if you want to do this again or with a different measure. Yeah.
Makes sense. Thanks.
And Mark, we've had one more question come in. I'm curious if through this process you pondered how you design a way of collecting this type of data that might be less wobbly. Seems to be the nature of the phenotypes and human nature as well, but curious if you have thoughts about a different design.
Mm, yeah, that's a good question. I guess we kind of we I guess this kind of research has been done a lot in um, like educational science, and that's what we kind of copied a lot of the methods from. Um, and I'm sure there are other ways that we didn't think of. I'm not sure I can really come up with anything on the spot, but yeah, I agree. It's probably wobbly and um, it's probably hard to generalize the findings to the general population. It might be representative of the group that we had, and yeah, um, I I guess yeah, it's hard to do this in a way that is truly stable. Yeah, I'm not sure.
Kevin, I'll come back to you, but I have one other person, Preeti. You can ask your question.
Yeah, hi. This is a great presentation. Very interesting work. I have a few different questions actually, but I think one of the more basic ones is, did you find any gender effects? Like I noticed that in the 7 scenarios you had like one Miss Smith and the others were Misters, like men, I assume. And then you have caregivers rating um, different aspects of these scenarios. And do you think that there's a potential of any sort of gender bias creeping into these ratings?
Yeah, very, very good question. We did have three Misters and three Misses, but and we did try to kind of have them spread across the trait, but yeah, it's something we didn't control for. I guess we could have not put the sex, we could have not put Mr. or Mrs., but that would have maybe made it a little awkward or something. I don't know. But yeah, very valid point. I do think that there might be some bias towards it. Um, I do I do think that generally on the Amsterdam IDL in like the real scores, we don't see sex or gender effects. So that might be a reason to think it was not that big of an issue. But I do agree. I guess we did think about, is there a way that we can just randomize the sex for every participant? But it was just like design wise, putting this in a questionnaire was not feasible. So
Yeah.
unfortunately.
No, it's really tough to do this kind of
Yeah.
research. I
Yeah.
completely empathize, and I'm kind of in a similar boat where I'm trying to sort through some of these issues. A related question, if I may ask, is did you find any other demographic effects, for example, effects of age or education? I can imagine all of them playing some sort of a role with, everyday functioning.
Yeah. Not to my recollection, not in the determining the thresholds. And then I'm trying to remember, we haven't really found that many. I mean, there's some age effects, but also our sample, both the sample of the caregivers who completed the questionnaire, but also our memory clinic sample, pretty young. I think the average age is around 65, so they're relatively young for a dementia population. So, yeah, it's hard to say what it might look like in older people. Um, but I think, yeah, generally they're pretty minimal. And I think one kind of way that the scoring kind of addresses that is through like not including activities that are not relevant. So, if you can imagine that somebody who's older might not use a computer, then we don't take that into account to compute their score. So in that way, we kind of very indirectly um, control for it a little bit.
And Kevin, you had one additional comment or question?
Yeah, just a quick comment because FDA is very interested, I think, in patient report, but I think FDA is also interested in that the intervention moves the target. So I guess I'm wondering, maybe for a future direction, if you've considered looking at how do changes in self-report, whether from caregiver or patient, how do those map on or relate to changes in the biological functioning of the individual? Changes in biomarkers. Are we getting similar information or different information or complementary information? I just think it's fascinating to look to see how these two different outcomes might track over time.
Definitely. Yeah, that's something I'm really eager to work on. So for sure, we'll look out for that.
Any additional questions from the audience? Well, if not, Mark, thank you very much for this very interesting and engaging talk. Do appreciate it very much. As I mentioned to everybody, later today I will post the recording of this webinar and send the link out to everybody so that it can be viewed later. But thank you for your attendance and be on the lookout for the next session in our webinar series. Thank you very much. And thank you again to Mark Doubleman.
Take care, everyone.
Thank
Thank
you.
you.